I'm going to be talking about role of nutrition in children with cleft lip and palate. So let me first tell what is cleft. So let me first give an introduction so it will be easy for you to understand what is cleft. Okay, so generally if you see cleft lip and palate is basically a birth defect that occurs during pregnancy, that is within 6 to 12 weeks it happens. So basically what happens is when the lip or the mouth, when it does not form properly, you call it as a defect. So this cleft lip and palate, you can also call it as orofacial cleft since it occurs in the facial region. So if you see, this is not, people think that cleft lip and palate occurs because of the genetic issues, and people think it's because of the fate things. You know, you would have heard people saying if you walk in the eclipse, the pregnant mother should not walk in the eclipse, and if they do that, their children will be born with cleft lip and palate and such kind of things. But if you see cleft lip and palate, they don't really have any much reason up to research. There are certain reasons for genetics, but you cannot tell that it's only genetics cause. Still the cause is like not yet found, but it's always better that we have to treat it. See, people think cleft lip and palate is a big disease or anything. It's just a deformity which can be corrected. But still, if you see, even though it might sound very simple and very easy, it takes it has to be managed properly. You know, babies with cleft lip and palate, they have a lot of issues like feeding. When you're starting from feeding till they get the surgery, they'll have to be in a good position and a good control. So let's see what it is and why nutrition is important. I'll just show you a pictorial representation of how it looks. So if you see the first image that I've presented here, it's a cleft lip. It's a one side, which is a unilateral cleft lip. If it's on both sides, you call it as bilateral. Also, if you call it complete when it is until to your mouth, and when it does not extend to your nose, you call it incomplete. If it extends until your nose, you call it complete. So there are different categories like unilateral, bilateral, complete, incomplete based on the deformity that is occurred. If you see the next image on the right side, this is your cleft palate. That is, there is a gap in your hard palate, hard in your soft palate. Again, if you see when there is deformity, that is the deformity is present only in the soft palate or only in the hard palate, you call it incomplete or complete based on your based on the deformity that is present in the babies. Now this is the deformity that I've been talking about. So let's see why nutrition plays an important role here. It's just a normal deformity, right? Why do people think that people have to look care and give proper criterias and observation and etc. So let's see why it is important. Okay, so nutrition, if you see generally for infants, it is very essential for the optimal growth and development. So the first 1,000 days of life, that is 270 days in utero plus 2 years, is very critical for good physical and mental health, which is this is for a general infants and general growth. So if you see during this pregnancy period of time, the maximum growth will occur in this period. And if there is malnutrition, that is a deficit in calories or anything, that will have a result in physical and intellectual stunting. So now we see if children with cleft, now if you see they're very much vulnerable, just like lactating mothers, pregnant mothers, elderly are vulnerable. Similarly, children clefts are vulnerable to develop malnutrition due to multiple factors, such as they might have feeding difficulties, they may not gain proper weight, and they might be they would have had intrauterine growth retardation, and there are even several other factors that can make the babies develop malnutrition. So therefore, the healthcare providers should be empowered to identify the malnutrition and provide proper intervention. So this is just a gist of explanation. So as I go on, you can look forward, and you have any doubts, you can ask me. So basically, before you tell that the child is malnourished or well nourished, there are certain categories where you do as assessment. So assessment, if you see, you call it as A, B, C, D, E, which we can use it for everybody else, not only for children with cleft lip or palate. This is a common thing that has been used. So since we are going to discuss about this particular thing, I have just elaborated on a few points. So when I go through the upcoming slides, it will be very easy for you to understand. So if you see A, B, C, D, E, A stands for anthropometry, which has nothing but your body measurements like height, weight, head circumference, mid-arm upper circumference. This is one of the parameters to assess nutritional status. The second nutritional status is serum albumin and hemoglobin. This, this is very important because these children, if you see they'll have to need surgery. You cannot correct it without surgery. So for them to overcome, for them to take the surgery, they need to have a good iron status, and they should have a good inbuilt protein status as well. So that is why it's very important. And clinical assessment, when it comes to whatever you say clinically, if there is visible wasting. Visible wasting is nothing but it's a terminology that is used when the weight for age is less than -2. I will explain everything in detail. So just make sure you know the keywords. That is very important. So when there's a reduction in body weight, or if there's a pital or pedal edema, that is if you touch and if there's like a swollen feet where you just put a hole, it will be like a picture. I'll just show you the pictorial representation so you will understand better. And if there are any signs of micronutrient deficiencies like xerophthalmia or anything like iron deficiency like spoon-shaped nails, or if there's pale, so these kind of things should be taken into account of clinical assessment. And coming out to diet history, you need to ask about whether using any supplements, the adequacy of the diet has to be taken. And the last thing is environment. So talking about environment, usually we only say A, B, C, D, right? Why is environment here? Environment, it happens when the environment where the mothers are being like put up, whether are they having proper hygiene, and what about the family history? Does anybody in the family, like when they have greater pregnancies, like more children, when they have, their chances that their nutritional status will be reduced. So to assess such things, we ask for the environmental history as well. So as I told you, this is the first thing that we'll have to look for. One is the anthropometry. Under anthropometry, if you see, you look for the height above 2 years of age, and length less than 2 years of age for children, and weight, mid-arm upper circumference, head circumference, skin fold thickness, and BMI. So these are some of the factors we'll have to measure. And there are certain Z scores I am going to come up over in the upcoming slides. And with this, you have to interpret what is the status. So some of the equipments you can use are for measuring this, or stadiometer, infantometer, infant weighing machine, and digital scale can be used to check. So if you see the interpretation, if you see, if the child, the Z scores which I was referring to, if it is between 3 to 97th percentile, which means the child is normal. And when it comes to Z scores, if the child is, the Z scores are between -2 and +2, it is normal. Now, I was telling you about the charts, right? So those charts are called as centile charts. It's nothing but it was developed based on the population. Like it's just like an average. Like if you go above the average, which means it is a healthy population, and you come less than 50, it means the child is something wrong with the child, and you have to have a dedicated medical referral. You have to go through it. So these are the centile charts that we're referring to. These are also known as growth charts. So if you see, there are separate growth charts, like from birth to 5 years, and then you have 5 to 10 years, and then you have 10 to 18 years. This has all been developed by the WHO. There are separate growth charts for girls and boys. Okay, so here if you see, the weight for age is, it's nothing but based on your age, you'll have to mark the weight here. And if you see the right side, I would have shown here is the weight for age similarly. If you see the below, it is nothing but length or height for the age. For example, let me say 5-month-old child is 60 centimeters. So you have to mark here. If you see the down, the x-axis and the y-axis are there. Okay, the y-axis, it shows your age, and x-axis is your length. So when you plot it, these are the percentile. So if the percentile is between the green color, that 50 percentile, if you see, it is normal. If you say below the 3rd percentile, it is abnormal. And even if it goes above the 97th percent, it's abnormal. So for using this interpreting charts, there are various methodologies. So first thing is WHO growth chart, which I just showed you. Second is there is a WHO Anthro software which we can use, and there is also an Android app which we can use for tracking. I'll just show you the app. this is the interpretation which we'll have to take in control of. So left hand side, if you see, these are some of the Z scores which one will have to take care. So the parameters that assessed under anthropometry will be weight for age, length or height for age. Length is referred for children less than 2 years. Height is referred when the child is about 2 years. And the weight for length. So if the Z score is less than -2 to +2, it's normal. Whereas if the Z score weight for age is between -2 to -3, which is, we call it as moderate underweight. And if it's greater than, if it's more than -3, you call it severe underweight. Whereas coming to the height, when there is when the range is between -2 to -3, you call it moderate stunting. And when it goes greater than -3, you call it severe stunting. Whereas the weight for length, similarly, if it's between the range of -2 to -3, you call it moderate acute malnutrition. And when it is greater than -3, you call it severe severe acute malnutrition. So this is some of the terms that we'll have to use when you're checking through the WH score, WH Z scores. So another point you have to note is head circumference. So when the head circumference is less than -3 SD, you call it microencephaly. So these are some of the other charts. Weight for age for girls, weight for age for boys, the same thing. I've just put it on for your reference. And this is again for weight for length for both boys and girls. So with this, we can easily plot. This is another chart which we can use it for plotting the head circumference. So if you see the y-axis, as I already told you, it refers the the age of the child. So let me just put an assumption: the child is 1 year, and if you see here, let's say the head circumference is 45. So if you just plot 1 year and 45, it will be in your mid range. That is, there'll be a green color curve that occurs. So which means the head circumference is normal. So this is how you check the reference scores. So I was talking about the Android application, right? This is available even in your Google Play Store. It's called Child Growth Tracker. You can just put in data like the height, the date of birth, height, and weight, and automatically you can calculate the Z scores of the child. Or it's only till 5 years, so it's only for children. Okay. And this is another indicator which we call it as a mid upper arm circumference. It's very cheap and it's very, very simple. You can use this kind of tape or normal tape, non-elastic tape. You can use it. So if you see, this is a very effective to find in communities. If you see, it is the most sensitive indicator of mortality when compared to the weight for height, and it is not, it does not have much of error. So this is used for children greater than 6 months to up to 4 years of age. If you see the range, if you see in the tape, if you see the normal range is when it's greater than 13.5, you call it normal. If the mid-arm upper circumference range is lesser than 11.5 centimeters, it indicates SAM. SAM means severe acute malnutrition. And I just tell you how it has been measured. If you see, this is measured in your non-dominant arm, where the measuring tape will be put from your arm bone till your upper limb to your lower limb bone, and you take a mid-range. So in the mid-range, you check the circumference. So based on the length, range, the data of the circumference, you call it either normal or the sum. Based on your indication that you get through the tape, the circumference value only tells you the mid-arm circumference value. So let's move on to the next thing. So as I was telling you, by the SAM criteria, there are certain ways to find out the nutritional status. So SAM is severe acute malnutrition, and the WHO, World Health Organization, has defined this as when there is a visible wasting. Visible wasting, if you see the first image, you can easily find out the child looks emaciated. And if you see the first image that put in the bottom, this is the stick. This is the one of the tape which we can measure the mid-arm circumference. If you see this child is, if it's lesser than 11.5 centimeters, again it's a criteria. And this, the last image in the bottom side is the pittle feeding edema. That is, if you just put your fingers in, you can fingers after touching the child's feet, you can still see the hole. That is called, when it occurs in both the legs, you call bilateral pitting edema. If it's just one leg, you just call pitting edema. So these are some of the criteria for SAM. So which is why we have to assess the child properly. So next we have to, as I already told you, I have covered the anthropometric. And now we are going to the clinical examination. So clinical examination, there are certain things like fetal feeding edema, angular stomatitis, cholangiocarcinoma, vitamin E deficiency, rickets, hand and skin changes, and the pictures of pallor. So I'll just show you. These are some of the clinical signs people can easily notice. One is the pallor. So you can keep the child or infant's hands above your hands to check the pallor, whether the child is pale or etc. So you can just compare. And feeding edema is another one. And angular stomatitis. If you see in the edge of the lips, they will develop these kind of issues. So it's a deficiency of vitamin A. This will happen. And cholangiocarcinoma, if you see, the nails are all spoon shaped. It's a deficiency of iron. And rickets is vitamin D. So the legs will be board shaped legs. And next is PEM. PEM is when the child has inadequate protein and energy. You call it PEM. That is very, very severe. It's called protein energy malnutrition. So in that cases, the skin will change because the child will not receive adequate protein and calories, which is why zinc, the child will have multiple deficiencies. So that is why you may get skin lesions and etc. So if you see, growth monitoring is very important because you have to monitor over a period of time rather than just taking one point of time. You have to keep following the child. So only then you can find how the child has been growing. So example, if you see, I have just made some notes here. Like, can you see the points below? So if you see, so it has to be a curve so that it will be easy for us to follow up. So every visit when the child you see, you have to plot based on the growth parameter. Only then you will be able to know the growth of the child, whether the child's growth is achieved or not. If it is not achieved, how can we go through it? So which is why we'll have to do the proper assessment. Now, sorry, is my slide visible? Okay. Hello.
Yeah, Miss Deepalakshmi.
Yeah. Okay. So all of this time I was explaining you regarding the assessment of the nutrition test. Mainly I covered anthropometry, biochemical, and the clinical examination. Now let's see what are the feeding difficulties that the child will develop in cleft. So if you see the child with cleft lip and palate, they cannot, especially infants, if you see, they cannot suck properly because they will have a negative pressure during suction. So you might think they might suck well, but at the same time, when you compare the energy that is received in the breast milk, and the child will be very much tired for the sucking. So what happens is you have to make sure that the child does not suck so much, lesser than 15 minutes. So only then the child will gain weight. If you make the child suck more time, like a prolonged time greater than 25 minutes or 30 minutes, the child will lose weight. The child will become tired and the child will not gain weight. So which is why that is one of the feeding difficulties. And especially when there is a complete bilateral lip, it is very difficult. And apart from that, there is a nasal regurgitation and choking. That happens because since there is a hole in the lip and the palate, the child, if the milk passes through your the lungs or airways, the milk comes out. So there is a regurgitation and aspiration that takes place, which could lead to choking. So you have to make very sure that you have to burp the child before and after feeding to avoid this regurgitation and choking. And another thing, since they have this, since they have a cleft, they have an excessive air intake and they feel early satiated. That's because more than the milk that they consume, the air will be, since the air intake will be more, they will have an early satiety. So which is why burping is a very effective technique. And as I told you, the baby will tire fast because the baby will suck for a prolonged time and they will be very much tired and they will not gain weight. And another thing is maternal will also feel discomfort and exhaustion. So if you see, there is no single correct method of feeding that has been identified. Every method will have to try out and figure which works. So whichever method works well for feeding, you have to go on with that. So let me just tell you what are the feeding options for cleft lip and palate children. So there are various methods. As I told you, there is no single best method that happens. For some babies, this method would be the best one. For some babies, this method would be best one. So I'll just tell you what are the things. So if you say direct breastfeeding, it can be given if it's a uniform, like when there is an incomplete lip, direct breastfeeding can be given, but you have to make sure that the feeding time is less than 15 to 20 minutes, and they'll have to feed both the breasts. Many people think when coming to the practice, they don't the mothers, they don't feed the baby very good. Like what happens is they keep changing the baby from one breast to another. So it's always good that you empty one breast and then you move on to the other breast, because if you see, the breast milk is composed in such a way that the child should get the entire nutrition. If you see, the first milk that comes, the colostrum, is very, very important. So there are certain kind of milks like colostrum, hen milk, fore milk. So since for the child to get the adequate nutrition, one mother has to make sure that the child empties the first breast and only then move on to the second breast. So these are some of the points should be noted down when the child is on direct breastfeeding. And cup and spoon can also be a good method. So mothers can express the milk through either medulla, any breast pumps, or they use the manual method to express the milk, and they can feed the child through cup and spoon. And indigenous feeding methods are there, like Nifty Cup and Palate. In my center, we try to use Palate because it's very easy, and many mothers and children find it very comfortable to drink. Another thing is a Nifty Cup. Nifty Cup is also, it's a basically US based product that can also be used when Palate is not being used. And there are also special bottles and special teats that is specially used for children with cleft lip and palate. And there are also combinations of special bottles. I'll just show in the upcoming slides where you see the pictures. And when nothing else can be used, the last option is nasogastric tube. But still, we are trying. Even when we get patients from outside, when there'll be babies with NG tubes, we will train the child and the mother to teach them how to intervene the child properly using other techniques. We'll maximum try to avoid using nasogastric tube. And earlier days, they were using some feeding plates prior, but it's no longer used in practice. So if you see, this is the feeding position you have to see. So it's always that the child should be in your one arm, left, if you're going to feed in your left arm, right arm. Okay, so it has to be, the child has to be in a degree of 45 degrees, head elevated. The head is elevated, the reason because the child should not have regurgitation. The milk should not flow through your any of the palate or your lip, or it should, what happens is, if the milk enters the airway, the child will have aspiration, the child will have choking, and it could also lead to death, which is why we'll have to train the mothers and encourage and motivate them to feed the child in a proper positioning. Positioning is very, very important. If the positioning is not proper, the child will get choking and regurgitation every often. So we'll have to avoid it. And not just that, the child, if there is a regurgitation and choking that happens, the milk can also flow through your ear and it cause ear infections, and in the future they might not even hear properly. So which is why feeding a baby with cleft lip and palate is very, very essential and very, very important. So remember that you will have to feed the child in a 45 degree head elevated. That is the most important thing here. So this is, again, as I told you, this is the correct position you're feeding, and this is a modified football position. You can use it when the child is on direct breastfeeding. If you see, again here, this child is also in a 45 degree head elevated. So you have to make sure that this is happening. Now, there are certain principles with the use of breast milk. See, breast milk is always the breast milk. You cannot compare it with any of the formula milks. So maximum, you will have to encourage the mothers to use breast milk, whether the mothers are directly breastfeeding or express, that should be prioritized. If the breast milk is not available or not sufficient, then you go for the formula feeds. So until 6 months of age, make sure breast milk should be given. If it is not possible, you go for formula feeds. But make sure you don't give, mothers think since the breast milk is not adequate. In my practice, wherever I see, they start using cow milk, buffalo milk, which is not good for the child. And mothers, what do they think? They dilute the milk as well. So what happens? Number one, you should not give cow's milk or buffalo milk to the child until 1 year of age. because infants, if you see, they cannot digest the heavy protein. When you compare the protein that is present in breast milk and cow's milk, the breast milk, if you see, it is 1.1 protein content for 100 ml, whereas the same cow's milk, if you see, it is 3.2 grams per 100 ml. It's like the double the time. The infants are very sensitive, and they cannot digest protein. And there are also certain infants who develop cow protein milk allergy. That is the cow milk protein. I mean, the cow milk protein, they cannot digest, and they develop allergies as well. So, which is why we'll have to encourage mothers not to use cow's milk or buffalo milk until the child turns 1 year of age. Maximum prioritize with breast milk. If not available, you go for the formula feeds. So, with adequate support, most mothers can breastfeed. You just have to give the proper confidence and have to support them. And mothers, when they're not, even when the mothers are expressing the milk, they should be trained in such a way that you have to make the child, put the mouth at the breast. Only then your milk will get secreted. The mother's milk will get secreted, because it will stimulate. Only if you put the child's mouth through the nipple, the milk will start producing. That's how the bodies are being connected. So you have to teach the mothers about gangroo mother care, skin to skin contact. Such things will make the mother feel better, and there will be a better milk production for the mothers. And the feeding device can be based on the family's choice, and you have to educate the family that the milk will escape through nose. So if it is expected, it does not indicate choking. And you have to burp often when they take in more air while feeding. So which is why before and after feeding, it's very important to burp the child. So you'll have to burp the child at least 5 minutes prior feeding. Next, if you see, you have to make sure the child feeds in 30 minutes. That is, as you told you, if it prolongs more than 30 minutes, longer feedings can cause the child get exhausted, and they burn up too much calories, and weight gain, there will not be a proper weight gain. So these are some of the things one should have it in their mind while seeing for the child with cleft lip and palate. So okay, so let me just talk about the benefits of sucking. So every mother should be encouraged to put the baby for breast for 5 minutes of each side. The baby may not have an effective suck, and if you see, sucking is essential for the emotional health of infants. So it's okay to suck, but not greater than 25 or 30 minutes. As I told you, it is not this. It's not sucking. It not only is just a source of food, but it also is it's a comforting factor. And if you see, breast milk sucking, it promotes a bonding between the mother and the child, and it also helps in the development of oral motor skills. And if you see, this sucking, it helps in stimulating milk production in the mother, and after 5 minutes, maybe you can express the milk and empty the breast regularly. So these are some of the points that you'll have to remember for breastfeeding. And the reason why breast milk is beneficial, if you see, any amount of breast milk is beneficial, especially for babies with cleft palate, because for cleft palate, you cannot feed the child, at least with the lip, you can go for direct breastfeeding. Children with cleft lip, you cannot go for direct breastfeeding, because there are greater chances of having regurgitation and aspiration of the milk. So it is very, very important, and you have to make sure you express the milk and provide it. And if you see, another important thing is, since the milk, even if it gets regurgitated, or even if it goes inside, breast milk does not irritate the tissues that's inside your nose or throat as much as the formula milk, because the babies, they have this irritation when you give regurgitation happens. And it also, if you see, breast milk will also help to reduce the risk of ear problems. So direct breastfeeding, it is possible, as I already told you, it is possible with isolated cleft lip or a narrow cleft palate. That is when there's only the palate is in the narrow part, not in the entire part. And you have to make sure that the breast will have to be mold to the gap that is present in the lip. And you can also, there are a lot of feeding positions for breastfeeding, but the 45 degree is important. You can have a hatch ball or a football. There are a lot of positions, and the nipple will have to stay at the back of the tongue. So a feeding nurse will play a very important role, or a lactation consultant will help with a proper feeding methods. It will be possible. So bottles, Moving on to bottles, I was already telling you that there are special bottles that is used for children cleft lip and palate. There are certain things known as Haberman feeder, Maid Johnson bottle, and Pigeon bottle. It's basically, if you see, it's made up of soft squeezable plastic, which helps to draw milk with the bottle with very little, even if they put very little comfort, the milk will be drawn. And you can also make a white cut in the nipple is tipped, because what happens is, I already told you that sucking will make the child lose weight when it's greater than 30 minutes. So when you make a long nipple with a cut, what happens is the milk flow will be greater. The babies did not strain or suck so hard. So which is why whenever bottle feeding is being given, you do a white cut in the tip, which is very, very much recommended. If you say Haberman feeder is designed, this bottle was designed by a mother of a child who is having PRS. PRS is Peary-Robin syndrome. That is, they will have the lower jaw will be smaller and the upper jaw will be greater, and they will have the tongue will be falling back for them, whereas they will have a lot of breathing problems. So for such babies, Haberman feeder is very, very good, and with a very weak suck, it is very important. It is very helpful. And another important thing when you compare to bottles is sterilization is very, very important. Another thing is there's a lot of studies to say that bottle feeding is not very that good when compared to other methods. The reason is, if since the use of bottles, if you don't wash the milk that is being used or the bottles when it's not sterilized properly, there are chances of diarrhea. So it is very important, whoever is using bottles, they'll have to sterilize the bottles every time they feed the child, so that the child does not end up having diarrhea. And another important thing, if the child is having a palate, so at the time of surgery, it will be very difficult for the child not to use bottles. So whenever they doing the palate surgery, the child should not use bottles. The reason is, at that point of time when the surgery has been done, what happens is, when they start sucking through bottles, the sutures, there's chances that the sutures might not be properly out. So at that point of time, it is not recommended to use bottles. That is the palatoplasty. That surgery is called palatoplasty. When that has been done, you should avoid bottles. So which is why from the start, whichever method is comfortable, you can go for it. So this is the Haberman feeder. This is how it looks. So if you see in the tip of the part, that's how the milk flows through it. If you see the another important advantage is, there will not be a black flow of milk. See, in other bottles or normal bottles that you see, if you just put in and take it out, there'll be there'll be a backflow of the milk. But in bottles like Haberman, there will not be backflow of the milk very much when compared to the other bottles. This is an advantage here. And this is the nifty cup which I'll be talking. You have measurements here like 20 ml, 40 ml, 60 ml. It is reusable, it is boilable, and you can also autoclave it, and you can just measure it every time. And if you see, this method is very soft with the silicone material, and the mothers can directly express the breast milk into this nifty cup. And there are this is the study to say that in South India, nifty cup was one of a well-designed thing, and we had worked it out so well. So this was one of the study just to talk about the nifty cup that was being done. So this is one of a child. So if you see, this is called the Palate, and this is how we give the milk to the babies. So just play the video.